You need to put yourself on mute. I think there is a lot of disturbance that way. Uh, Dr. Zubeda, can you hear us?
Yes.
Yeah, she is there, so she can hear
Yeah,
us.
Dr.
Yeah,
Zubeda, we need your video as
Yeah,
well
I'm
because
just.
we,
Hi
yeah,
there.
hi.
Hi,
yeah,
hi.
yeah.
Getting into a
So
session. Can I call you?
we are waiting for Dr. Dipti.
Sir, Deepthi madam will be joining within few minutes, sir. She had some urgency, so she asked us.
Okay, I'll just I'll just join in a minute. Yeah. So 3 o'clock is it, Raju?
Sir.
Yeah. Take it. Take it.
Sir, in a few minutes, Deepthi madam will also be joining, sir. She
Yeah.
just informed.
Yeah. Fair enough. Fair enough. Fair enough.
Yeah, but
That's why I'm
Raju,
joining
we
you in a
start
minute.
sharp by 3, huh?
Yes, ma'am. Yes, ma'am.
Because the discussion can go longer.
Yes, ma'am.
Hmm?
Okay, ma'am. By
It's
3 she will join, she said.
Esther. I may have to leave in the middle.
Uh-huh.
I'll start the thing. I'll introduce all the faculty, and I I'm not sure because there is a CDSU meeting, so I
Acha,
may
you
have
are introducing, is it, Harsh? Because I actually included this thing to introduce the panelists.
you do it. You reduce my workload. I'm more
Yeah,
than
I
happy.
shared it with them. They are also okay with it.
ठीक है, perfect. No, no,
Huh?
no. What I do is I'll introduce you and I hand over to you.
Yeah, yeah. I'll
Fair
give the
enough?
intro and then I'll introduce all the panelists
Hmm.
and then we'll get started with the questions immediately.
ठीक है. So I'll start the program. I'll introduce you and then I hand it over to you.
Hmm.
Right?
Hmm.
Done. Done. I'll just join you in a minute. Just give me a second.
Yes.
You're going to start with me? तो निकाल दे, मैं चूज करूंगी। यहाँ से भी निकाल सकती है। तो पीछे जा बेटा, तू जरा मोबाइल आगे नहीं करना। Second, I'll just
Okay. Esther, shall we start?
Yes, let's start.
Yes, I think let's start. It's not good to keep everybody waiting, right? A very good afternoon, ladies and gentlemen. This is Dr. Harsh Chaturvedi of Pulse Pharmaceuticals, welcoming you to this discussion on a very topical issue of nutrition and longevity. While it was communicated to me that we are going to have a brainstorming session on this subject, I recollected, it was probably.
Let me in.
Hello. Okay. So I think we had something coming in between. So, okay. So where was I? So I believe it was the year 440 BC that the Greek physician Hippocrates said, "Let food be thy medicine, and let thy medicine be food." His wisdom over the years has proven true, since we now know that altering the level, the type, the timing of food consumption, and fasting is perhaps the most potent, feasible, and the safest intervention to improve health, extend longevity, and I would use the word, not the lifespan here, I would use the word health span, which probably is more pertinent, you know. In fact, I was thinking that the fundamental relationships between nutrients and cellular responses are so conserved in unicellular organisms, right from unicellular organisms to the humans. But despite of the extensive research, the type, the quantity, and the combination of nutrients that optimize health longevity remain highly controversial. In addition, there is increasing evidence which suggests that human nutrition must be adjusted to age, gender, genetics, and metabolic risk status of an individual, and that tailoring the specific dietary recommendations is essential for the full benefit of these beneficial effects to be realized. So, to understand and harness these evolutionary conserved mechanisms, in addition to personalizing dietary interventions, is the key to optimize a human health span and longevity. To learn about these, we have invited experts on the subject from across the country who will be sharing their knowledge with us today and their experience. And we all know that this will help us in designing better diets for a health span. I welcome you again to this very rich learning experience. Before we start, it's my privilege to introduce to you. I'll be sharing my screen. Uh, the moderator for today's program. Uh, our program is entitled Nourishing Longevity, Addressing Protein and Micronutrient Needs of the Elderly. Ladies and gentlemen, this has been organized by Pulse NutriScience Private Limited. I'm a part of it. And it's a privilege to have Dr. Esther, who is Head Clinical Nutrition at HCG Hospital, Bangalore, with us. Dr. Esther will be moderating the session today. I'm sure everybody knows about Dr. Esther, but it's customary, so I'll be speaking a few lines about her. Her professional experience is spread over 20 years in clinical nutrition, especially in oncology, gastroenterology, and critical care. She has been actively conducting workshops and awareness programs on oncology nutrition, and she is an executive member of ISPIN. We all know about her academic credentials. They include PhD. She is a registered dietitian and a program director with fellowship in oncology nutrition at HCE. She has numerous publications in peer-reviewed journals on cancer nutrition and internal and parenteral strategies. Her research is more involved on chemotherapy-related fatigue and high-protein diets in breast cancer. And she has presented her work at various national and international forums. She has spoken on these forums and is a very sought-after speaker and presenter. With these words, I welcome Dr. Esther to today's program. and I hand it over to her. She'll be moderating the program, introducing the other faculty members, and taking us through the day. It is over to you, Dr. Esther.
Yes, thank you. So, Dr. Harsh, if the slides to introduce other panelists are there, then let it be.
Okay.
Okay, because I am
Okay.
not sharing any slides.
Okay.
Okay,
Fair enough.
so welcome everyone. Good afternoon to one and all. This wonderful afternoon, we are going to discuss on something that Dr. Harsh has just given us an introduction on. It's about nourishing longevity. The whole world is talking about living long and living healthy. So, with three amazing experts, we are going to be discussing about how do we handle these kind of people when they come to our OPD settings or in our IP settings, where we not only deal with a disease condition, but just talk about healthy living as such. Our population is aging, we all know that, and we know that proper nutrition helps them to not just live long, but also live a healthy life. Like how Dr. Harsh said, it's not just lifespan, but the health span. So I'm honored to be joined by three experts in the field. We have Dr. Zubeda. Dr. Harsh, can we have the slide on Dr. Zubeda? So Dr. Zubeda Tumbi is the founder and director of Health Watch, a nutrition clinic in Mumbai. She's a PhD in clinical nutrition. She's got over 20 years of clinical experience. She is actively involved in patient care and constantly sees patients and learns from the different kind of cases that she sees and teaches all of us. So thank you, Dr. Zubeda, for being here. Thank you for participating and thank you for sharing your insights that we are all going to hear from you. Then we have Ipshita Chakravarti. Thank you, Ipshita, as well. She is the head of the Department of Dietetics at CK Birla Hospitals, CMRI, Kolkata. She's a very senior head nutritionist. She has over 25 years of clinical experience. She is again actively involved in seeing patients both in the IP and OP level. And she has a lot of accolades to herself, and it's an honor to have her here with us. Then we have Dipti. Dipti, can we have your video on? Dipti Khatuja is the chief clinical nutritionist at Fortis Gurgaon. She has over 20 years of clinical experience. Her areas of specialization include critical care nutrition, handling cystic fibrosis, and also chyle leak management through nutrition. Thank you, Dipti, for being with us, and thank you for giving us this time where we discuss about this. So thank you all for being here. Let's get started with an interesting discussion. So we are not going to have slides. I'm sure a lot of you have had a lot of webinars where slides are there, and it is a monologue. But today, what we're going to do is have an healthy discussion between three experts. We will have a set of questions, and they will use their experience and also their knowledge to help us navigate through those questions. We will also take questions from the audience after we are done with the flow, and they'll be happy to, address your questions as well. So before we come up with the solutions for the problem, which is, uh, healthy aging, let's understand what are the challenges that the challenges that an elderly person faces. So Dipti, I start off with you. Could you highlight the key psychological and age-related changes that the elderly undergo during this process of aging? Not just in terms of the changes that can impact the nutritional needs, but also how the calorie requirement might decrease, but the density of nutrients might have to be really good at. So, as a nutritionist, how do you deal with this challenge?
So thank you, ma'am. Thank you so much for, first of all, a lovely intro. And thank you, Pearls, for having me over here. And I would say that, yes, geriatric is now becoming very challenging and very important to treat, at a mass level. And for nutritionists, it is important first to understand how these changes do impact their requirements. So I would say the most common ones why their energy levels requirements are decreased is because of the physiological changes, that there is a lack of or decrease of the physical activity. Their metabolic rate slows down, and lot of digestive issues also, they face up, which they are not able to tolerate most of the foods which they probably used to tolerate in the adolescence and at the younger ages. So these physiological changes have a drastic change. On the other hand, if we see with the age, there are high increase in the calcium losses from happening from the bone, and also the absorption. The combination of foods, I think, as a nutritionist, is something which I always focus when I'm dealing with the patients or with my geriatric populations. And I would suggest a simple example, having when I'm taking a dietary recall or a history or having a discussion with the patients or their families, I would commonly hear they are having a cup of tea with, a nuts or probably some healthy makhanas and all. And we all know tannins and caffeine in tea and coffee, they will impact with the nutrient absorption, and there have to be, sorry, adequately spacing out of these nutrients. Similarly, we get a lot of feeling that, probably the aerated drinks like limca and all, they give immediately pain, and we are relieved with the gastritis. But on the other hand, it is leading to a lot of the calcium losses if the if the intake is very high. So as a geriatric, when we are dealing with it, the first and the foremost thing is to assess their nutritional requirements, understand, and their, apart from physiological changes, I think economic factors, their food security, knowledge level, and combination of foods are very, very important to deal with situations, and always provide them with the calorie dense food, not giving them too many bowls of eating, but probably just making a nutrient dense in terms of adding everything in one meal, and probably something which is easy to digest. So for me, I really normally prefer to recommend my patients something like smoothies as in between snacking, where you can put nuts, where you can add a healthy source of easily digestible protein source like curd, and a teaspoon of oats into it to give the thickness. And that's how they can add fruits to it, they can add vegetables, seasonal vegetables to it, and have a good healthy snack rather than having tea, cookies, or something like namkeens and all.
Right.
And one more thing which is commonly seen is the dentures, that they are not able to chew. So giving them in the consistency which they can follow, I think that's very, very important when we are talking about the nutritional requirements and changing the meeting their nutritional requirements for geriatrics.
Right, right. Thank you. Thank you so much, Dipti. So it's clear that aging brings about a lot of changes in the body in a very complex manner. So let's go a little more in depth with the challenges that geriatrics face. So moving on to Ipshita, appetite, swallowing, and sensory changes. Now, Dipti did cover in terms of dentures, but we also see that people as they age, they face a lot of changes in their appetite, in their swallowing, in their taste, sensory parameters. So how do you handle this among your people, and what you know? How is it that we can deal with them while we are looking at giving adequate nutrition?
Thank you, Esther, for a kind introduction, and thank you, Pals, for organizing this on World Food Day. So we are celebrating age-old issues in a very appropriate day, because universally our lifespan is increasing.
Right.
So to deal with that, we need to focus on geriatric population, so that at that age they should be kept healthy, because our parents, our grandparents, they have reached that age, and we, the caregivers, we at home, we need to focus on their dietary pattern and dietary issues, because we know with age, I mean, elderly population have lots of comorbidities, and what should I say, like lots of dysfunctions happen, like reduction in food intake, immune function reduces, some diseases happen like CVD, IHD, COPD, respiratory disorders, renal impairment, even Alzheimer, Parkinsonism. Few cases, Esther can better say that onco cancer is a very, very common thing these days. So considering all these diseases, we need to focus on what already Dipti has shared, we need to focus on the concentrated calorie and nutrient and the protein part of it. Of course, considering the blood workups which is done. So we need to focus the dietary habit, GI tolerance, what patient can digest, in what form patient can have. So food intake, of course, it goes down because of Alzheimer and Parkinsonism, and because of cancer, they might have dysphagia and can't chew properly, denture issues. All these are there. So there we need to, even in my case practice, I can say that if needed, ONS can also be given intermittent, like around not four major meals. It can be split into separate meals, like little bit of breakfast and around 11 a.m. Some ONS not in a glass full of liquid because patient may not have so much of liquid at one go. Some concentrated form, then some lunch, and in the evening, if patient is used to in having some tea and all, then after that, instead of giving some chirwa and puffed rice and all those namkeens and all, instead of that, some concentrated ONS can be given, which will give enough energy, enough protein, and enough whatever deficiency is there. And we as dietitians, we can recommend what kind of diet we should give. So considering that, we need to focus on type of consistency of the food. Small frequent meal, as I have already shared, it should be well cooked, soft, easily digestible. So we need to choose that kind of food items what are good for that particular person, and patient can digest. Patient won't have strong stomach issues on that, and little bit of exercise and yoga kind of thing, if patient can be is mobile, and if doctor can allow, if there is no hindrances on that. So these all can help a patient to lead a healthy life, and they can prolong their lifespan, I should say. Thank you.
Okay, so we discussed about psychological changes, physiological changes. Let's also look at a challenge that the elderly face in terms of absorption. So we know that the elderly population have reduced gastric acid, and there are some absorption issues in terms of micronutrients. So Dr. Zubeda, looking at your expertise, could you discuss how reduced gastric acid production affects the absorption of a few key nutrients, like for example vitamin B12, and how as a nutritionist would you handle this challenge? We know that there are certain absorption issues that happen with the elderly, and when you are aware of that, how do you identify it? Number one. The second is, how do you deal with it as a nutritionist?
Thank you, Esther, for the wonderful welcome. And it's great being with Ipsita, Deepthi, and you, of course. And thanks, Pulse, for this very thoughtful event, especially so on World Food Day, because we all are looking at a lot of patients who are across. I would say I see more of patients who are 50 plus, 60 plus. And when we are doing the assessments, when we do the blood works, we often find that many men, women are deficient in B12, D3, calcium, iron, even magnesium, and that you can already see in their status when you look at their height, weight, when you look at their body fats. And very importantly, it all boils down to the gut. So we know that aging leads to gastritis. There is a lot of use of proton pump, inhibitors. There are antibiotics being used. There are a lot of drugs being used because a lot of these 60 plus population will come with comorbidities.
Right.
When we are looking at their nutrition and digestion, then becomes the first part where we like to help out. So when we know that there is reduced gastric acidity, there will be a reduction in B12 absorption, because B12 comes from proteins, and we all know that B12, the source is animal proteins, and of course some abortive milk products. So for that, when we are planning diets, we got to make sure that the person in his meal will have some kind of source of vitamin C. Okay, and when he's eating, we'll make sure that he does not combine things like iron, calcium, because we know that vitamin C as well as stomach acidity is required for the absorption of B12, iron, as also protein digestion. And we all know that protein, the adequacy of protein along with B12 and iron and B6, B9 are required for a better blood profile. So overall, if you want to look at the person's health, and activity status and energy status. As Deepti and Ishita discussed, that elderly do have deficiencies and they have a decreased basal metabolic rate, but they also have a higher BMI in some cases. In some, they are very low for their height and their age. They are low in weight. And some are, I would say in Mumbai, I see more of the patients coming with overweight, obesity. So both ways, I find that yes, when you look at their food, they are lacking in proteins, are lacking in vegetables, they're lacking in acids. And yes, of course, the increased intake of colas or antacids is very high. That again all impacts the absorption of B12, iron. Yeah. So when we are looking at vitamin D, see, when you look at assessments, I often get at least B12 along with the CBC. I will look at their C-reactive protein. Inflammation is so high of late. So I would look at vitamin D as well. And then I would look at supplementing that along with a good diet. So diet, as we all know, will focus on macros, your healthy carbs, healthy proteins, and healthy fats, along with micronutrients, like especially vitamin D and B2 supplementation comes in line. And then we have a good team of NDs, then we all work on improving on that status. So the nutrition, I will tell them that, look, have your vitamin D, with a good, say, milk or some good protein and fat, so that absorption is enhanced. Like for B12, we'll see when a person is non-vegetarian, it's very easy to introduce eggs, liver, organ meats, and that too in forms which the person can eat. It can be a mince meat, it can be a soft cut, it can be a soft poached eggs. Because if it's very hard boiled, again, digestion will be impaired.
Right.
So we look at all those combinations and we look at, giving them, say, if they can't, say, eat an orange or say an apple or a pear or a papaya, we'll say, grate it, add it to your raita. So then curds come in. So when you have curds or you have these probiotic enriched yogurts nowadays, those are wonderful combinations to enhance their B12, vitamin D, vitamin A, intake along with the food that they're eating. And vitamin C comes in very easily, I feel. Sprinkling some lime or, making a chutney or a dip with coriander, mint, amla is in season. You can bring in even those raw mangoes. So, and wherever they can afford or wherever it's available, bring in avocado. So all these dips can be good ways of introducing soft in texture foods to enhance their nutrition absorption and nutrition composition.
Right, right. Thank you so much. Okay, so let's move on to a very, very pertinent question. It's about sarcopenia. Now, I think among all the disease conditions that we see, one thing that we learned about sarcopenia is from the elderly. Rather, it is from the elderly that we learned about this definition of sarcopenia, and then we tried applying it among hospitalized patients, among oncology. I use I use the term sarcopenia a lot more often. But we learned about this term primarily from the elderly. We understood that, people who are living in community dwellers and nursing homes, they had, of course, less BMR, that is, the energy requirement is less, but they also noticed that as they were aging, muscle depletion was really high. So, moving on to all the panelists, sarcopenia, we understand, is a major concern among the elderly. How do we deal with that? How do we deal with sarcopenia among the elderly? Is just giving a high protein diet enough? Or is it that there are some practical steps apart from just focusing on proteins in dealing with sarcopenia?
I think I
So,
would like to talk about sarcopenia. This is my pet
yes,
topic as well, because when I tell a person to, look at their rate, how much of fat to muscle ratio, we have those
right.
body fat composition analyzers. And some who can afford, they do the DEXA scan. And there we can tell them, look, where is your visceral fat and what is their muscle mass or what is their bone mass. And when the person walks into your room, the gait, the speed, the posture again tells you about what is the level of muscle loss, bone loss, and the person's nutritional status. So when I talk about enhancing their protein intake, I would say that how many of us, even today, if I ask even our own fraternity, how many really take care to intake the amount of proteins we need? If you look at, say, just 2 bowls of dal and 1 cup of curd, I mean, that's all you get to eat from protein. So we are really deficient. Even if you are a non-vegetarian, we all have our feasting and fasting days. So eggs, non-veg becomes like only twice in a week or thrice in a week. So most of us are protein deficient. And that's how we have got muscle losses, which is sarcopenia. And sarcopenia is linked to bone loss, no? Sarcopenia, osteopenia, osteoporosis, and age, they are all four things working hand in hand, along with, say, nutrition. And then I would say the importance of exercise. How many of us really take out time to do a little walk? Or for that matter, if I tell a person, look, I'll teach you some yoga asanas or I'll teach you some weight-bearing workouts, just wearing wearable weights, they are saying, I didn't even know that you can wear weights to improve on resistance. So when you look at resistance training, wearing weights or using TerraBands, I train my patients. I spare 10 minutes for that as well. And then, gradually I should look now, look at your hand grip strength. Even use a monitor to see what is the strength. So then we show them that, look, now 2 months back, you were so frail or you were like so weak. You were so low in strength. And now look at the change in your status. So it is not just losing weight that we emphasize on. We look at losing your fat and improving on your muscle and bone health. So we look at, of course, improving protein intake. So we require supplementation. Because in elderly, of course, when we talk about chicken, mutton, dal, they'll say, I get gas, I get bloating, I can't digest, I get constipation, I get loose motions. I mean, you get so many reasons for not eating right or not eating adequately. So we talk about easier combinations, like I think Irshad was talking about cereals and the dal. So I would say that when I talk about khichdi, I say, improve on the dal fraction, make it half-half and add some vegetables. Or then you bring in some curd. So when you have combination of cereal pulse with a curd, and that becomes close to a complete first-class animal protein. For those who are not vegetarians, it's very easy to bring in egg or say bringing in an egg and cereal or egg and millet pancake. So besides the protein adequacy with food combinations and supplements, we talk about vitamin D. We talk about calcium because the vitamin D, calcium, and magnesium are sufficiently given along with the good protein and carb ratio, and the person will see a better muscle to bone ratio. And we then will aim at more of fat loss. And I know it is not impossible, but it is possible to improve the muscle status at any age. But that will come with exercise. And we all know that if you're resting too much or sitting too much, you don't even absorb much calcium. And when we tell the patient, okay, please go out in the balcony and sit there or stand there, do on-the-spot jog, or just do free hand workouts with exposing your arms and your thigh beneath your legs, so that sun exposure comes in. The little tips go hand and go very well in improving their health status.
Yes, excellent insights, Dr.
Ma'am,
Zubeda.
one thing which I would want
Yes.
to add on over here, absolutely agree of what Dr. Zubeda has said.
Yeah, excellent
And I
insights.
think
Yeah.
that's where now the improvement has been done, where ma'am said that just losing up the weight, we need to see the muscle strength. And I think there the body composition analysis becomes very important rather than just checking a normal weight. And I think as a clinical person, all of us now, most of the hospitals do have, but I think that's something which should be made mandatory because bioimpedance method, something which is very commonly with our OPD patients. And I think that's more practical to look on day-to-day basis with the bioimpedance method about the muscle mass strength.
True. Yeah, I think the points Dr. Zubeda covered were fabulous. Like she spoke about resistance training. She spoke about not just proteins, but the micronutrients that need to go with it. She spoke about hand grip strength. So sarcopenia is not just muscle depletion; it's also a reduction in functional capacity of the individual. And if we don't understand how the functional capacity is reducing, we will not be able to really intervene to help them build or improve the functional outcomes. And how is it that a dietitian, so earlier, our OPDs used to just have a weighing scale and sometimes no weighing scale at all. But now our OPDs are a little more sophisticated rather. So we have to look at functional outcomes. We might have to see how it's like she mentioned about the gait of the person. So when a person is walking in itself, we understand the gait speed. We can understand the sit and stand test by just looking at them. We can look at a few nutrition focused physical examination to see to what level of muscle depletion the person is having. Hand grip dynamometer, and something that you really brought up well, in terms of having a body composition analyzer, because that really helps. And as we know that Indians, we technically are high on visceral fat and low on muscle at baseline itself. And if we don't understand the baseline, we'll not be able to understand what our targets are and how do we achieve those targets. So great points from both of you. So moving on back to
I would
Ipshita. Yes. Yes,
I
yes.
would
Coming to
like
you
to
only.
add something.
Yes.
This is nothing to do with our fraternity, but the social issues are becoming very like heavy on senior citizen and this elderly population. Maybe
Right.
their children are staying abroad, they are staying alone. Maybe presently they are single, like either of the spouse
Yes.
has passed away.
Yes.
So having those items and the foods and the nutrition, whatever the person who is taking care, whether getting those things at home, these are also becoming very relevant issues these days, because they are all alone. Even there is nobody to look after, taking, giving the medication, purchasing the regular things, regular food items, regular medications. That these all are creating impact on overall health also. This is nothing to do with dietetics, but
Yes.
these are all
Yes, I
social
think
issues.
yes, very, very true. So I think, so when a patient visits a doctor, the doctor gives a prescription and the patient leaves. But when the patient comes to the dietitian, for some reason, the dietitian not just takes care of nutrition, she takes care of physiotherapy, like in terms of exercise.
Absolutely.
She takes
Totally.
care of psychosocial needs, like she has to understand who's the caregiver, educate the caregiver,
Absolutely.
make sure that the caregiver understands all that we are trying to explain.
That's
And
what I'm saying.
she also has to deal with the mental status. So sometimes, I think that we are professionals who have to have knowledge not just about medicines, but also about not just about nutrition, but also about a whole lot of other things like social issues. How do we manage the individual with the social issues? How do we manage with the psychological changes that come in with aging? Like people
Absolutely.
end up having dementia, end up having Alzheimer's. Then the caregivers become really important. And in India, I think every time a patient comes in, they can come in with a different caregiver. So it kind of becomes really important that the family is
Who's the
involved in.
exact person who is
Yes,
taking care of
yes,
that?
yes. And apart from that, even this functional outcomes. I think when we were studying nutrition the decades ago, we never learned about functional outcomes. I mean, we never learned
Absolutely.
about hand grip or the 6-minute walk test or the sit and stand test, and now we have to look at the balance of the individual when they're coming in, and look at nutrition to deal with all of those things, because I think the world is moving towards a more patient centric outcomes. So it is about a quality of life living rather than just survival. So it's not about so a lot of times, if I have to look at it in terms of oncology practice, the doctors are very happy that the patient is surviving, but are they surviving with a good quality of life? And that is very similar among the elderly. Okay, we are happy that they are living, but are they living with a good quality of life? And when we talk about quality
Absolutely.
of life,
Absolutely.
all of these functional outcomes come to play. So, moving on to you, sticking on to you, Ipshita, how is it that you will advise such an individual as they are aging in terms of proteins and micronutrients? Of course, Dipti and Dr. Zubaydah, both of them gave inputs. But if you have an elderly person sitting in front of you, how do you specifically talk about the nutrient requirements? Just for the understanding of the audience, how do you end up calculating? How do you end up moving that calculation into a diet plan?
See, energy requirement might decrease by 400 calories per day with age. So, roughly requirement decrease by 0.5 to 1% per year. So, as it is an elderly population, their intake and their requirement goes down, especially for those who are totally bed bound, they are not mobile. So, their even their disease condition requirement is requirement based. Whether it's increased or decreased, it entirely depends on the what kind of a disease that particular patient is having. So what we normally do is energy expenditure, Harris Benedict equation. These are all for our calculation and all, but this is not like patients or caregivers won't understand exactly what that what that means. So most of the patients can be fed an energy level up to 100 to 120% of the estimated basal energy expenditure. But in few cases, as Dr. Zubeda was saying, because of immobility, patient might gain weight, they become obese. Some because of lack of nutrient, because of sarcopenia, they might lose weight, they are frail. So we need to consider everything, and considering that, we need to decide on the protein part and the energy part. So basically, a baseline of non-protein calorie requirement, at least 25 to 30 kilocalorie per kg per day, should be given to for the energy requirement. And the protein also, a baseline of 1 gram per kg per day has to be given, considering other, like renal impairment is there, creatinine is on the elevated level, and creatinine is soaring up. Patient is not in a condition, that elderly person is not in a condition to go in for dialysis. So there also we need to focus the protein intake. Even patient might have GI issues, might have hepatorenal issues. So there we need to consider the protein intake part of it. Otherwise, at least 1 gram per kg per day, it might go up to 2 gram per kg per day, depending on the disease condition. So that way we need to explain the caregiver what type of protein, what type of calorie, and how to give that calorie, what can be the concentrated way of giving it. And for suppose they lose their appetite, they have decreased appetite, so if we give ONS, we can give little peptide, some formulations which are peptide based, little fermented food, so that which are easier on stomach, because they are already pre-digested, so stomach doesn't have to work a lot to digest those. And of course, hydration needs to be maintained. Dr. Zubeda already mentioned about the physical activity. So as much as possible, patient has to be, if not proper physical activity, just roaming around in the wherever that person is staying. So that activity also improve the satiety, improve the digestion also. So basic practical dietary approach, it has to be calorie dense, it has to be spaced out meals, protein concentrated, and that also easily digestible. So we are focusing on the protein part, but that doesn't mean that we can give little bit of chole or rajma or something of that sort, which is not easy on stomach. We can't give so much of mutton. It is easier for a non-veg patient, as I am catering to this area where I am working, which is a predominantly non-veg eating population. So there we can give fish, and a Bengali person, elderly person, is quite happy with fish. So it can be given both times a day. So that also is sufficient for a person to have adequate amount of protein, little bit of curd, little bit of cottage cheese made out of low-fat milk. So these are the easily digestible, soft things which can be given, and the, I mean, protein and dietary intervention can be taken care by giving all these in the diet.
Thank you. Dr. Zubeda, what do you want to add on protein, the list that she started off?
I
Or
think
Dipti, do you want to add on to that list of
for proteins,
nutrition
I
intervention?
always feel that when you start with their dietary recall, our patients, when
Right.
you walk into our
Yes.
rooms, you often see that their breakfast is just about tea and biscuits in most cases, or rusks or bread. But then when you talk about, where are your proteins, and then you start with how you can look at, see, not all will have eggs. So then you bring in some kind of dals or sprouts. That too is not acceptable. So you bring in curds. Then you bring in paneer. Then you bring in combinations of boiled dal with wheat or any millet. Make it into a paratha or a thepla. So you talk about even hung curds. Because when I say hung curds, just take your own curds, put on your sieve, discard the water. So the quantity becomes less. Because we see that when you have an elderly person and a person is not too well, you don't want to eat too much. You think of how to make it more, palatable, more attractive. So then combinations come in the picture. Then you can teach them how to make dips and spreads and pancakes and dosas and chilas and of course
Right.
upmas. So when you make an upma as well, I would say you don't put water, you add curds. Yeah, you can add more of fresh peas. So we have to think of all the possible ideas as per the season and as per the person's religious beliefs
Also.
and family. No, what is
Right.
the family support? Because I always tell them that, see, when you make an upma in this manner and when you have it with, say, with a dahi chutney, the entire family will have a better nutritional status. It's
Right.
not just the person himself. When looking at, say, idli, I would say, don't just give idli and chutney. You can bring in a sambar. Or if it's a dosa, I always say, my fusion dosa recipe. I said, bring the dosa with eggs in it, or bring paneer or cheese with some vegetable which can be grated, which can be mashed up, or where you can just grate and add or even mash up with your dosa batter. So easy recipes which are made as per the person's familial ideas and the
Right.
caretaker. Because I often end up even counseling the caretaker. Suppose if
Yes.
it's the husband, and tell the wife, look, you two can eat like this, you two can have similar proteins, so you two will become a little better in health.
Mm.
So I think looking at not just the cereal protein combinations, I would say, talk about your leafy vegetables, how they can be used in an easier fashion and easier for digestion. So
Right.
bringing in those combinations can help. And I always talk about, improving their B12, vitamin D, along with magnesium. See, seeds. Now we talk a lot about pumpkin seeds, sunflower seeds, sesame seeds. And I tell them that these can be just lightly roasted. You
Mm.
make it into a powder, add it to your chutney, or add it to your dips, or add it to your fruit milkshake, along
Right.
with some protein supplement. That becomes like, one meal on the go. Just one porridge or one thick shake can give you at least 20 grams of protein. So it is not difficult, but yeah, we can convince them into eating right.
Mm.
We have
Right.
to put in a little extra effort for that.
Yes.
That's all.
We are holistic
Yes.
counselors. No, Ipshita, we
I
talk about what the family eats, what they buy, how much they can store, what they can prep up and keep, what the entire family can eat. Then we talk about exercise, dance, music. I also tell them you keep an alarm. Don't sit for more than 1 hour in the chair. So when that alarm buzzes, you got to leave that chair.
Yeah.
Simple, simple things.
Diptik, moving to you, can you throw some insights on supplements? We are talking about ONS, we are talking about multivitamin and multimineral supplements. So Dr. Zubeda and Ipshita spent a lot in terms of natural foods. But what I
Hmm.
want you to add on is in terms of supplements, because I think as nutritionists, we need to be aware of what kind of supplements, when is it that we include these supplements, and when is it that we are careful to start using the supplements? So over to you.
So, thank you, ma'am. And yes, I think at this geriatric age, supplements can play a very, very important role, because when we are talking about the energy deficiency because of so many factors or micronutrient deficiencies, so the guidelines suggest that normally one at least 433 calories and 30 grams of proteins coming from the supplements if they are really deficient into it. And as Dr. Zubeda and if Dr. Ipshita rightly said, we can use them rather than, like Dr. Zubeda said, normally tea and biscuits is their breakfast. Or when I come across, I normally hear having as in between meals snacking, they would have tea and cookies or tea and namkeen. So I think that's the time when we can actually give them the supplementation, and we need to understand that it is not replacing the natural food that we are giving, but it is over and above that we have to give to minimize the deficit and bring into a better immunity and reducing the risk of mortality and risk of infections for geriatric patients. The most important thing, apart from the supplementation time, it is also equally important the mode or the method of giving the supplementation. So as as Ipshita rightly said, peptide based or semi-elemental or pre-digestive formulas, specifically in malabsorption cases, in specifically where digestive issues are there. I think they play a very, very important role, not just in the digestion, but also the absorption of the micronutrients. And we should but on the other hand, I always say that we have to be careful, because in today's time we have a lot of generations, and including the geriatrics, where they blindly follow the supplementation. You talk about the vitamin D supplementation, where hypervitaminosis has also become a challenge in today's time.
Right.
So rather than going on the blind supplementation, I think getting back to the nutritionist, rightly going through with the supplementation in the given doses, and if required, then supplementing it through supplements is the key that we need to take if not met from the natural food sources.
Right. Right. Okay, so let's
Even
wrap
different
it up because
companies have
yes, Ipshita.
just one thing. Even different companies have come up with some products which can be added with the food, which doesn't have any taste or flavor
Right.
or anything of that sort. So those ONS can also be added in the food like dahi or dal or something of that sort, so that you don't have to give extra additional food to that person, but
True.
with normal meal that can be added, and that will add the protein content of the
Also,
meal.
yeah, absolutely rightly said. And one thing more, that now in today's time, we are all talking about the foods which are being imported. And I think the major area is that we need to work on the locally available fruits, which are much cheaper, based on the geriatric population, the income, the psychological support, easily available. Something like basil seeds can, at one third cost, but same nutritive value of the chia seeds and all, can do the replacement into smoothies, and that we have been talking about the natural foods. Similarly, the moringa powder, which is being very common in south and in north, if you actually see, provides a lot of nutritional value. So definitely we can go for locally seasonally available foods. We can change their sources and can be used as supplementations for with the natural food, for
I
sure.
think, Esther,
Right.
regarding, supplementation, I think when we are looking at a person's blood works, right? And when you look at vitamin D, normally we see only 10, 7, and the minimum is 30. And when we see that 90% of the patients who walk into my clinic, I see that not many are even about 20. So, and when doctors have not seen that, level, I normally feel that we as nutritionists can recommend 60,000. I would say straight away take 60,000 a day for 8 days. That brings it to 4.6 lakhs in the first week. So that the person starts feeling in the next sitting, that I'm feeling much more better. Because enhanced vitamin D can, and then you can bring it down to 2,000 IU per day.
Right.
Some cases, even 5,000 IU a day is, I would see, having a lot of benefits on the person's overall muscle, bone, and immunity status. So that is important, because one cannot say that you can get vitamin D from your fortified milks. It's not possible, because deficiency of vitamin D can impact the person's overall health. So that is very important.
It is
You
also.
can give by a soft gel or you can give by liquid. But this, 8 days in succession, followed by, either 2,000 a day or 5,000 a day. And then you assess after 3 months where the person is. Because you will see a definite change in the person. See, now you see a lot of patients with steatosis, fatty liver. You see patients with cholelithiasis. You see that, of course, when Deepti mentioned and Nipshita mentioned that a lot of elderly are now single, their children are all abroad and they're staying by themselves. So we know that the quality of nutrition is not so good. And so
Right.
the lifestyle is not very healthy. So we need to look at these, because I find that mostly you'll see a lack of vitamin D, B12, and very many are anemic as well. And they don't even realize that anemia is because of low intake of iron-rich food, as
Yes.
also B12 is less. So it is
Right.
overall holistic understanding of the case.
Right. Thank you. Okay, so let's close because we have some 8 minutes before we close. Before we wrap up, I just want each of you or any one of you to discuss any successful programs or interventions that you have had, or, from your experience, anything that you have read about, maybe recent evidence that you feel is impactful in dealing with the elderly population. Any one of you, Dipti, Ipshita, Dr. Subeda, anybody, any interventions or any impactful steps that the person, the family can take in terms of what you have read or what you have evidenced or what you have experienced?
I think one is, enhancing the protein status. So building on the protein adequacy, because now I was reading of one study recently that they're saying that you should make sure that the first meal gets 30 grams of protein.
Right.
How many can, say hands up, I'm having 30 grams of protein in the first meal.
Right.
Mostly we see people having a heavy meal in
We
the
do
dinner.
not have.
So
We
first
also do
meal
not
can
have.
be 30 grams.
We also do not consume. If I say like normal population, do we? We are not.
So that is what, when I tell my
That's
elderly,
right.
like when I had this lady, 65-year-old with advancing CKD, she was a long-standing type diabetic case, and the doctor just put her on a lot of drugs. He thought, okay, drugs pay. If I put her, she's going to be fine. She was brought in by a son who, Google searched me and he brought her to me. ठीक है. And I said, okay, when I looked at her nutrition status, she had stopped eating proteins. Doctor has said low protein diet. So our lady stopped.
They stop eating all protein sources.
All dals, all non-veg, all stopped. And then she became frail.
Absolutely.
She could hardly, stand up tall. And now with 3 months, I say that she's bettered her hemoglobin status just by nutrition intervention. Her proteins are better. I removed the fear. I put her into eating, fish, egg whites, yogurt. Said, why the fear? If anything goes wrong, then I will refund all your fees to you. That was the only thing I had to, say, start eating. Start eating, and you see, now she's so much better. And then one more doctor said, no, your inflammation has come down. Yes, your creatinine levels have come down, and you're in a safer zone. And also, fat livers came down from grade 2 to mild. So that is, intervention improving on the organ status, the bone status, the muscles, and the person's self-confidence. I can eat.
Right. Anything you would like to add on, Dipti or Ipshita, to what she
So
said?
I would say also it is important that the permutations and combinations of the food would play a very important role. And something which Dr. Zubeda initially said, the dosas and the idlis, I think fermentation and the sprouting process can greatly take care of the micronutrient deficiencies. And some common programs which were run was Pradhan Mantri Arogya Yojana. I think that was something where they specifically focused on the referral, post discharge referral for the elderly, and getting into the geriatric clinics and geriatric healthcare facilities available. I think that's something which is very, very important. And now as you rightly said, it is not the survival, but the quality of life,
Right.
which plays a very important role. So I think nutritional education, not just to the caretaker or not just to the patient, but also I think the medical fraternity, along with the whole medical fraternity, the patient as well as the patient family members have to be taken care of, and definitely available of these geriatric clinics would play a very important role, specifically in the remote areas where we would see
Right.
a lot of helpful for these geriatric populations.
Right.
One thing
Ipshita, yes.
at the end I would like to add, do not self medicate, because we in India have a tendency to go to the pharmacy and buy something. So stop having any OTC drugs. So this is not going to help you without knowing the impacts of it. So do not never ever give. Do not skip any medications, because they're under the impression my pressure is normal, so let me stop this hypertension medication. So ultimately they end up in ICU having the hypertensive attacks. So these are all small basic things. So whenever needed, please consult a dietitian, of course, a consultant, a doctor, and lead a good, healthy life. Do not self-medicate. Do not go overboard taking your own decisions. So that I
Right.
should add.
Right.
So
Okay.
it is
Shall we open it up for people if they just have any questions to ask the three experts? If the audience, if you have any doubts or any clarifications you need or any questions you'd like to ask, either you can unmute yourself and ask, or you can put it in the chat box and we'll be happy to address them. Yes, somebody has raised hand. Can you ask, or if you can unmute yourself, you can ask directly, or you can just put it in the chat box.
We can't hear you. Please unmute yourself and then ask.
Yeah, we're not able to hear you. Raju, can you see whether you can unmute her, or can you just put it in the chat box and we will read it out for you? Anyone else in the meantime can just ask the questions in the chat box. Okay, so this is not related to not directly related to the elderly population, but there is one question: is jamun powder beneficial for people with diabetes? And calculation for nutrition. I think Ipshita, can you take that? Calculation for nutrition. Can you tell that again, ma'am? Dr. Zubeda and
Basically,
Ipshita. Yes.
what I had shared, decreased physical activity. So you can consider around 400 kilocalorie deficit decrease in the requirements, depending on the age and status of that particular person. And roughly the requirements decrease by 0.5 to 1% per year. So again, we can calculate and we need to consider the age of the patient. Disease condition, we calculate our energy requirement by Harris Benedict. It's an age-old formula. We all started learning from that formula itself. So most patients can be fed through the energy levels of giving like 100 to 120% of the estimated basal energy expenditure. In obese patients, little hypocaloric. For sarcopenic, lean thin patients, there we can give little hypercaloric. But baseline non-protein calories should come from 25 to 30%, 30 kilocalorie per kg per day. That we need to focus. And baseline protein, 1 gram per kg per day during, can be given, should be given for a protein requirement, where low protein is not required for that particular person. For a normal population, normal geriatric population, this should be the basic calculation.
Dipti or Dr. Zubeda, do you want to add on to anything?
I'll just add
Yes.
on.
Yes.
When we're looking at proteins, we should look at least 50% coming from your first class.
High biological value.
Because a lot of us are purely vegetarian. So one has to, break it down for the patient and show them that, when you have just a plain wheat chapati, this is just 2 grams. But when you add something, as we all know what we can tell them to add, like milk or curd or dal, then your protein will go up per chapati. That is a combination. But the first class protein coming from your milk, curds, say cheese, paneer, eggs, fish, whatever. And I would say that fiber is lacking majorly. When we teach them about 15 grams per thousand or 1500 calories of the total diet, there if you teach them how to count, that okay, if you have your one bowl of salad or one bowl of leafy vegetable, and when you're elderly class, they hardly have any salad. So showing them how to, convert that into, say, like a smoothie or a vegetable smoothie or a dip or a soup, or adding it to their khichdi, or, mashing it up in the dosa batter. Those can be very valuable ways of adding on to the fiber and building on the protein content.
Right. Okay, I think she's unmuted herself, the person who raised the hand. You want to ask the question?
Yes, ma'am. Hello,
Yes.
ma'am. Am I audible?
Yes, you are.
Very sorry, ma'am. I just got logged off. Actually, I had a session here at my company. I was giving session regarding role of food in the prevention of cancer. Very sorry, ma'am. I am really I'm into the session. I couldn't get the time to visit your session here. Please, can you just briefly tell what you all have discussed, because your people are very inspiring to our younger
Okay, that
generation
is,
like
yeah,
us.
so that is not, but I think that the whole session is recorded. So you will, if
Okay,
you have
ma'am.
registered for it, it will be you will get in a recording, so you can hear all of us speak again. So it's
Definitely. Thank you so much, ma'am.
yes, thank you. Okay, so there are a couple of comments. I'll just read them. In India, there is lack of awareness about food supplements because we are not promoting health education in local languages. Most product labels are in English, which is true. And consumers cannot really fully understand. To improve public health and safety, it is important to have labels and awareness programs in Hindi. True, very true. All of us practicing in hospitals, and also people who are all of us running the clinic, we have education material in local languages as well. But yes, food labeling is not yet in local languages. There's one other comment in terms of many families think that elderly people should be advised by the doctor about medications and food patterns, whereas the caretaker itself becomes the doctor while treating the elderly people, but weren't asking suggestions from dietitians. True, true. We are in India, so there are a lot of challenges that we face. So let's wrap up because it's 4 o'clock, and I think Ipshita and Dr. Zubeda, all of us, I think, need to get back to our OPD patients who are waiting. Yes, Dipti, you
Sorry.
have a comment.
So
Yes.
I think one most important thing related to this, the information is also about the myths that we have in India.
Right.
regarding whether you talk about the permutation or you talk about the seasonal intake of the foods, combination of the two foods. And I think that's where, as clinical nutritionist, we can put a major emphasis again while providing a health education to caretakers and to families, and also talking about the combinations and the permutations that I've been talking about. I think that's very, very important. We should be focusing on.
True,
I
Dipti.
think, Esther,
Yes.
when we are doing our consultations and when
Yes.
we show the patients about the drug and nutrient interactions,
Right.
and we always educate them about, see, this drug, this side effect, how
Yes.
long. And if you will do this diet, you will get, a lesser return to that drug.
Mm.
Then that patient will come back to you and ask you that, okay, help me live a more healthier life, lesser drug dependent, lesser comorbidities.
Right.
The
Right.
power of counseling is very important, and we shouldn't let
Yes.
ourselves be,
Education is very important. Yes, very true. That's what I said. I think, we don't just play roles of nutritionists. Somehow we have to get trained in cognitive behavioral therapy, motivational interviewing. We have to play the role of
We
psychologists to,
ourselves have
you know,
multidisciplinary
to make
approach.
sure that, we need to, we need to become physiotherapists to make them go for their exercise. We have to become. So I think, our role is very, very multifaceted. And I think the three of you have done a fabulous job today. So thank you so much for giving in your time, your valuable insights. Thank you, Dr. Zubeda, Dipti, and Ipshita. Thank you so much for all the discussions that we have had. And throughout this 1 hour, we had over 100 people who were with us. So I think the session was very, very interactive and, enlightening for the whole team. So thank you so much. The whole team of panelists will be there in terms of, if you want to reach out to any of us, reach out to Pulse and they will connect, us to you. We are available on call and email. All of us are involved in building the community up. So thank you, Pulse, for organizing this, and thank you for giving us an opportunity to interact with each other. Thank you. We wrap up.
Thank you.
Thank you so much. Happy Diwali to everyone.
Yes, happy Diwali to
Happy
everyone.
Diwali. Thank you.
Happy New Year. Yeah, bye.
Yes.
Bye.